Hello everyone, welcome to Noble Psychiatric Services presentation. My name is Dr. Ondieki. I'm one of the guys behind Noble Psychiatry and Noble Pathway. I'm excited to welcome you to this presentation. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we encounter individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions that affect not only their mental health, but their families, relationships, and the quality of life. This is why this conversation is important. Today, we will explore bipolar disorder in a practical, evidence-based, and clinical relevant way aimed at improving patient care and strengthening our approach as mental health professionals. Thank you for being here, and we will get started. This presentation is produced and designed by the Noble Psychiatric Services. At the conclusion of this session, you'll be capable of distinguishing the concept of bipolar 1, bipolar 2, and cyclothymic disorders with clarity. You will be provided with a functional overview of the neurobiological basis and the diagnostic difficulties of the bipolar spectrum disorder. You'll be familiar with the existing evidence-based skills of pharmacological and non-pharmacological therapy, and you'll be sensitive to the traps of diagnosing and management, including the common comorbidities. These goals will support our deliberate process and assist in focusing you on a feasible clinical pillar. This is to provide you as the trainee or the person listening to this session with a confident systems on how to assess and provide treatment planning and continuous care to the patients with bipolar disorder. When we look at the epidemiology, a significant mental health issue in the world is bipolar disorder. Approximately 1% of the population is afflicted with bipolar 1 and 3% bipolar 2. It usually starts late adolescence or young adult, but the diagnosis can also be later in life. Men and women equally suffer, but women presentation may tend towards the depressive cycle, while this affecting the disease interferes with employment, schooling, and family, and it is associated with excessive hospitalization. Patients are under increased risk of suicide and premature deaths involving cardiovascular as well as metabolic disorders. Bipolar disorder is chronic and recurrent, and therefore early identification and lifelong management of the condition greatly decreases the amount of suffering and enhances the life outcomes. The etiology: there is a high biological basis for bipolar disorder. The high hereditability has been established as a family, and the twin studies establish a huge or large contribution of genes. There is a tendency of the neurotransmitters out of regulation, dopamine, serotonin, glutamate, and GABA, that influence regulations of the emotions and energy. There is a structural functioning alteration in the brain, such as the change in the prefrontal and the limbic functioning, that affect the mood stability and impulse control. Abnormalities in the circadian rhythm and the sleep and wake cycle also contribute or stimulate the development of mood scenes. Biological vulnerabilities may additionally be affected by the environmental stress, trauma, as well as substance use. The biological underlying cause also aid in understanding the fact that bipolar disorder is not mere moodiness, but a system disorder of the brain and needs to be treated periodically and also psychologically. When we think about the diagnostic criteria for the manic episode is a brief episode, not less than 7 days of continuous elevated expansive or irritable mood with heightened goal-oriented activities or energy. Patients become less likely to sleep and become more talkative, have inflated self-esteem, and have their ideas rushing, and they participate in impulsively or dangerous activities during a mania episode, including spending money recklessly or engaging in unprotected sex. These symptoms result in apparent disability in social or occupational functioning or hospitalization because of safety reasons. There is also a possibility of psychotic symptoms. It is important to understand that mania characterized by the bipolar 1 disorder excludes the presence of substance-induced or medical conditions like hypothyroidism or the use of corticosteroids is also essential before the diagnosis is absolutely verified. When we look at the hypomania and the depressive episode, hypomania is similar to mania and is less intense, lasting about 4 days in a row, but is less severe. Patients can be viewed as productive or creative at times, yet the close ones will observe behavior in a way that they are not used to. Depressive episodes are categorized by 5 symptoms, at least 2 weeks: the feeling of sadness, inability to enjoy pleasure, exhaustion and craving, sleep or eating alteration, feeling of guilt, and also thought of suicide. Periodicity in the bipolar disorder is the main diagnostic characteristic. It involves specific mood swings, which are not usually functioning of an individual. The clear determination of the two poles help avoid confusion of the disease with another one and treating it as unipolar depression, which is incorrect. As far as the subtypes, in the bipolar 1, there must be a minimum of one manic episode, which is usually alternates with the depression. Bipolar 2 disorder implies hypomania and major depression episodes, but does not include full mania. A less severe chronic variant is called cyclothymic disorder, and it is characterized by constant variation between hypomania and subdepressive symptoms that persist at least 2 years. There are patients who have rapid cycling over 4 episodes in a year, or mixed characteristics, coexisting mania and depressive symptoms. The disease is usually chronic and might get worse with time without the use of maintenance therapy. Untreated disease can result in worsening cognition and psychosocial status over years, and this makes early and constant care absolutely significant. When we look at the differentials, differential diagnosis can be used to prevent misdiagnosis of bipolar. The major depressive disorder does not have any mania or hypomania episodes. A bipolar personality disorder presents severe and transient mood fluctuation associated with relationships as opposed to actual instances. ADHD may look like hypomania, vitality, where else stimulants abuse or withdrawal may appear like mania. Considering any medical or substance use such as thyroid disease or exposure to corticosteroids or neurological disease. An elaborate patient and family history is essential, particularly on patients past high mood or sleep disturbances. It is likely that it will be misdiagnosed, and many patients will first be given antidepressants only, which is capable of helping the symptoms become even worse, leading to mania. As far as the comorbidities, bipolar disorder patients have extra psychiatric and health conditions, though anxiety disorders, which may be panic or generalized anxiety, occur in almost half of the patient. It is also typically and may cause relapses, use of substances such as alcohol and stimulants. ADHD is also confluent with distractibility and also impulsivity, making it hard to diagnose. On the other hand, on the medical side, there is common metabolic syndrome, obesity, cardiovascular disease, and thyroid dysfunction, partially because of the side effects of the medication. These comorbidities cause more hospitalization, less treatment compliance, and poor quality of life. Holistic management requires comprehensive evaluation and lifestyle changes, along with the communications with primary care and addiction units or addictions teams. When it comes to treating acute mania needs immediate stabilization to avoid damage and recover operations. Lithium and Depakote, or typical antidepressant Seroquel, Risperdal, or aripiprazole are the first line of agents. It indicates that severe cases might require different choice treatment. The main objective include reduction of the agitation, the normalization of sleep, and the prevention of safety. Lithium is a gold standard that has good anti-suicidal ratio, but requires periodic monitoring of the serum levels and the kidneys and the thyroid problems. Depakote works well, especially in mixed states, and must be monitored in regards to liver as well as platelets. Typical antidepressants have fast actions but have accompanied by risk of metabolic complication, including weight, glucose, as well as lipid. Patient education and early intervention is absolutely beneficial. As far as the treatment for bipolar depression and maintenance, in many cases, bipolar depression is more disabling as compared to mania. The best evidence has been found as far as treatment. Seroquel, lurasidone, and lamotrigine are better treatment of depressive phases. When the person is stable, continued therapy to avoid relapse is more important. To continue with the mood stabilizers or antipsychotic in a modified dose. The antidepressants are to be used with care, and one should use it should not use it by itself, since it may lead to mania or quick swings. Alerts on appearances, metabolic statuses, and side effects also aid in avoiding the likelihood of recurrence. Such aspects, such as maintenance, as regular follow-up visit, patient education, and lab monitoring are crucial. The long-term outcome is functional decline and full recovery. As far as the psychosocial and non-pharmacological treatments, psychoeducation improves awareness on early warning signs and knowledge of the illness among patients and families. CBT is important. It deals with critical thinking and fostering coping, and as far as coping mechanism, the interpersonal and social rhythm therapy concentrate on the stabilization of the routines and the sleep schedules and minimize the triggering of the episode. Communication and support are enhanced with family as well during this therapy. Management of the lifestyle changes, including exercising, proper eating, and alcohol or illicit drug abstinence, help considerably to decrease the risk of the relapse. The plans enhance drug compliance and the general operation. It requires a combination of medical, psychosocial, and psychological care in terms of wellness over a long period of time. Special population bipolar disorder manifests itself differently according to the age group. The young people, it is typically the young ones to feel irritable and have mixed features. Thus, precautionary diagnosis is required to differentiate ADHD or any behavioral problems. Older populations have medical comorbidities and lower mean renal or hepatic clearance, prompting increased judgment of the drug dosing and checking drug interaction. Pregnancy, the risk and benefit on the pregnancy postpartum requires the most frequent risk and benefit conversation with something like lithium or Depakote having fetal consequences, whereas untreated disease can cause potential and threat to the woman and the infant. Cooperation with the obstetrician teams is definitely important. Due to the insurgent cases, ECT and more recent neuromodulation therapy are both probable and secure under appropriate supervision. Besides, personal care gives better patient safety as well as results. In conclusion, bipolar disorder is a lifelong but manageable condition. Timely and correct diagnosis saves the patient years of needless torture and aids the patient to become stable once again. The process should include maintenance therapy, compromising pharmacological, psychosocial, lifestyle to avoid the relapse and hospitalization. The best support system is an interdisciplinary team of psychiatrists, psychiatric nurse practitioners, primary care providers, and therapists, as well as families. Raising awareness of patients to keep track of their sleep, stress levels, as well as medication compliance. Your listening skills, educative capabilities, and trust are also capable of severely impacting the recovery pathway of the patient. With that, this brings ourselves to the conclusion of this presentation about bipolar. Hopefully you were able to pick and take any key takeaways from this session. You're able to learn something. If you do have any questions, you can always send us an email or you can always put a comment and we'll be glad to follow up with you and answer the question. With that, I want to thank you again for taking your time to listen, and hopefully you did walk away with something. From Noble Psychiatric Services, here we come to an end.